Okay, so we are going to do a combined lecture on cancer care, which is chapter 12, and palliative end-of-life nursing, which is chapter 13. So these chapters provide the foundation for understanding how nurses prevent, detect, and manage cancer. Again, cancer is such a big, vast specialty. We're going to talk a little bit about the basics and talk about how we can prevent it, detect it, and manage cancer, but also how we can support patients through the end of life journey and through palliative care. Here are your learning outcomes for the end of this PowerPoint. You should be able to explain these concepts. So cancer is described as a uncontrolled growth and spread of abnormal cells. We have two different types of tumors. There are benign tumors and malignant tumors. So benign tumors are usually well differentiated or well defined. They can have an even border when they're looked at under a microscope. They grow slowly and they usually remain localized or in one spot. They rarely cause death unless they compress vital structures, whereas malignant tumors usually grow rapidly, they invade nearby tissue, and they can metastasize or spread to distant places through the blood or lymphatic system. So it's really important just to know benign versus malignant, understand, kind of the structures of them, what they look like. But malignant tumors are usually very rapid growing. They don't have defined borders. They spread quickly, whereas benign tumors are in one area. They usually grow slowly. Okay, so those are usually your definitions of each. So nurses play a vital role in primary prevention, which is vaccines. So primary prevention is preventing a disease or an occurrence of cancer before we are exposed to it. So those types of things are going to be vaccines like for HPV, smoking cessation, so increasing our or decreasing our exposure to toxins or carcinogens, or lifestyle counseling. So that's primary prevention. Secondary prevention focuses on preventing disease or illness from occurring once somebody is exposed to it. So that would be things like screenings for breast cancer. Maybe we are exposed to the gene for carrying breast cancer, so we need to do screening. So mammograms frequently, self breast exams. Maybe we are exposed to HPV through unprotected intercourse, and so we want to do our cervical screenings through our pap smears, screenings for colon cancer through colonoscopy. So secondary prevention means the person has risk for or has been exposed to something that could cause cancer, and we're doing screenings to catch it early. So prevention and catching cancer early is very important and a part of our nursing process. So management includes patient education on potential treatments, side effects for treatments, and psychosocial support. So making sure that we support the patient when they're going through cancer, talking to them about their goals and what types of things they want out of their treatment. So for our goals for cancer care encompasses prevention, early diagnosis, looking at a cure, so whether that's surgical or medication treatment, we maybe want to try to cure it, or we want to control it as much as possible from spreading, or we want palliation. So maybe we're not going to cure it, we're not going to fully get rid of the cancer. That's palliation. That would focus on symptom relief and quality of life. So sometimes a patient with a cancerous tumor, a malignant tumor, maybe goes in and has surgery to just remove part of the tumor that maybe is pressing on part of the brain that's decreasing function. And so they won't fully get rid of it, but it's going to increase their quality of living. Okay. So we always want to prevent, above all, prevention's number one. We don't want them to get cancer at all. Secondly is early diagnosis so that we can catch it early and we can do treatment early. That gives patients the best prognosis or outcomes. And then if we don't catch it early, we want quality of living. Okay, so what can we do to make sure the patient has the best life possible while they're either getting treatment or they have cancer that they're living with? So some treatment options that we see commonly when we're out in the medical facilities, they're going to be surgery, radiation, chemotherapy, or a combination of all of them. So sometimes treatment includes combinations of these, which works together to fully eradicate cancer cells or, at least shrink tumors or decrease what's going on. So surgery would be a complete removal of a tumor or a debulking of a surgical tumor, which would decrease the size of that tumor. Again, if it's impinging or encroaching on a space of another organ that's decreasing quality of life. With radiation, we can give internal radiation therapy or external radiation therapy. When we look at external radiation therapy, this is basically taking a radiation beam and you're lining up exactly where it is, where the cancerous tumor is in the body, and shooting a beam of radiation right at it. Now, things we worry about with external radiation therapy for our patients is going to be skin breakdown, okay? Because it's basically like a lightning bolt of radiation to the skin. So this is going to cause burning and breakdown of the skin. So for our patients, we want to do good skin care. So cleaning with a mild cleanser, nothing too harsh or abrasive like a washcloth or anything like that. So a soft cloth, mild cleanser, making sure the water is not too hot, not too cold, because we have skin breakdown, integrity breakdown. We want to make sure not to use any lotions or creams or perfumes. You can use a little bit of aloe vera cream if needed for the skin to heal, but we don't want to put any lotions or creams or perfumes or anything. We also want to leave that wound or that skin open to air so that it can heal. So don't cover it up with a dressing or anything like that. We want to limit sun exposure since it's kind of like a sunburn, right? We don't want to take this fresh burned up skin out into the sun to where it can burn up even more. So really protecting that skin and making sure that it's okay. Now, when we look at internal radiation therapy, this is usually done with rods or beads where these radiation seeds, they kind of look like little seeds. They have radiation in them and they're placed inside of a tube. It almost looks like a straw of macaroni and or a straw of spaghetti, and it's placed inside of the patient's skin and it's into the tumor cell, the tumor mass or the mass itself. And so those little beads of radiation go directly into the tumor. Now, those can stay in for a little bit of time, longer periods of time, so that radiation is right up against those cells, killing those cells off. Now, this is called brachytherapy as well. So brachytherapy or internal beam radiation. This can be done through those straw-like things or through a catheter that's placed directly into the skin tissue surrounding the tumor. Now, with these patients usually are exposed to radiation for longer periods of time. They'll put those seeds into the tumor and they'll leave them in there. So remember, our patients are radioactive, essentially. So your nursing interventions for them are going to be isolate them by themselves so that they don't expose somebody else to radiation. So you're not going to go into their room frequently. You're going to kind of go in and spread out your care. You're not going to spend a lot of time in their rooms. So they do have risk for isolation. So make sure they have a way of communicating via phone or computer with their families or things like that. They also are going to not see their families really. You're going to limit visitors, keep the door shut. You might need to wear like a lead apron or a lead vest when you're exposed to them to help decrease radiation exposure to yourself. Okay, so that's for internal radiation. Then we have chemotherapy. So chemotherapy is a drug. This is a medication that we give to the patient that kills all cells. So chemotherapy does not only target cancer cells, it will wipe out all cells. So that's why your patients who get chemotherapy are oftentimes exhausted, they're wiped out, they lose hair, they have renal impairment, they have liver impairment. It just damages all the cells of their body. Okay, so chemotherapy kills all cells. Now, we also have some therapies that are targeted where it goes in and targets and kills just the cancerous cells. But these are a little bit more specialized. They're not for everybody. and they're a little less common. You guys are going to see it a lot at Mayo. They do a lot of targeted therapies and stem cell transplants and immunotherapy and things like that. So you'll see a lot of specialized things that they do at Mayo, since that kind of is their specialty. So just pay attention to that while you're out doing your clinicals and things like that, and ask lots of good questions. Then we have surgery. So again, we may remove that entire tumor, or we may utilize it just to provide palliation. Okay. So let's see. Then we have immunotherapy. Immunotherapy helps to harness the immune system. So we can actually force our immune system to create T helper cells that will actually change into specialized cells, whatever we force them to become. And we can actually target specific molecular targets to help minimize harm to normal cells. Okay, so that's immunotherapy. So again, a lot of these treatment modalities are specialized, so you're not going to know the ins and outs of all of them unless you become a chemo nurse or you're doing your rotations on those cancer floors. But really, we need to be aware of surgery, what our nursing interventions are for surgery, both pre-op and post-op, what radiation therapy, internal and external therapy, what our nursing interventions are, and then how chemotherapy works. And again, chemotherapy kills all the cells, not just cancerous cells. And this is also something they would want to be on isolation for. So chemotherapy can be very toxic to nurses. So make sure that we're wearing correct PPE. We are covering the toilet when they flush. We're getting rid of their bed linens and things like that, because chemotherapy can leak out in body fluids. Okay, so when your patient's sweating, bleeding, peeing, then the chemotherapy can leak out of their body that way. So protect yourself as well if you see somebody on chemotherapy. So pretty straightforward here for our nursing process with cancer care. Obviously, our assessment, we want to do a good physical assessment, a psychosocial emotional assessment. We want to look at medications that they're taking, looking at their support system, educate them on treatment side effects, make sure to set realistic goals for them, paying attention to pain and comfort, making sure that we include the patient and family. This can be a very high stress time for our patients and our families. So making sure we really use that therapeutic communication, open-ended questions, and making sure that we coordinate care with the interdisciplinary team. So spiritual services, get them in, right? If the patient wants to talk to a chaplain or a spiritual services person, get nutrition in. Maybe they need extra protein or they need extra food in their diet to help with the effects of those chemotherapy or medications. Get our providers in, right? Maybe they need somebody to focus on their kidneys. Maybe they need a palliative or pain management doctor at the same time. So really get your entire team together. It's a big, giant undertaking to help somebody through cancer. Our evaluation, we want to make sure we evaluate, focusing on how they respond to treatment, how their symptoms are coming along. Are we making them better, making them worse? And do they have quality of life throughout what we're doing? Okay. Sometimes we're not going to have quality of life. Sometimes we're not going to cure them from cancer. And so we need to look at shifting into advocating for comfort care measures and end of life care, which we'll talk about in the next slide. Okay, so when we look at palliative care versus hospice or end of life care, palliative care can begin in any stage of an illness. Palliative care focuses on symptom management, particularly with quality of life and pain, and focuses on communication and psychosocial or feelings management. Palliative care is care that we give patients when they have a terminal diagnosis or something that, is kind of end of life, but those patients still want to find curative treatments. Okay, so maybe your patient has cancer and they want to be in palliative care, so they want high quality of life, they want pain management, they want to focus on all of the benefits of palliative care while they're getting chemotherapy. Okay, so we're no longer curing the disease process, but we might be doing treatments that are prolonging life in a way. Okay, so maybe they're still on a little bit of chemotherapy, not because they're going to cure the cancer, but because they're getting a little bit longer of a life out of that chemotherapy treatment. Okay, so palliative focuses on end of life, quality of life. Okay, now when we look at hospice care, hospice is a specialized form of palliative care because we're still looking at quality of life, but this is reserved for patients who usually have a life expectancy of a year or less, okay? Usually physicians have to say yes, they're pretty sure that these patients will have a year or less to live. And what we're really looking for is that quality of life. So these are for patients who usually have stopped all treatments, okay? So treatments that are prolonging life. So they no longer are getting chemotherapy or radiation or things like that. And they're focusing only on that psychosocial, that comfort, and that quality of life. So patients in hospice, if they ask you for a beer, you're going to give them a beer. If they want to go out and smoke 5 packs of cigarettes in one day, you're going to let them do that because that's the quality of life and that's that comfort for their end of life. Um, with hospice, we might see higher levels of pain medication. So don't be surprised if you have a hospice patient and you're pushing 20 milligrams of morphine, okay? Yes, we understand morphine will decrease the respiratory drive. Yes, we understand morphine might kill them, but it's not focusing on prolonging life anymore. So we're focusing on comfort care. So whatever we do, we keep them comfortable. We usually will limit equipment. So your patient may not have vital signs taken. They may not be on a heart monitor. They may have, just their family around and spiritual services around. And really, this is just a time for death with dignity. Okay, so we're starting to get them in that transition for end of life. Okay. When we look at communication with our patients that may be in end of life or hospice, we want to make sure that we utilize empathy, right? Utilize active listening, making sure that we're present in all that we do. We want to make sure that we are culturally sensitive. So if somebody has a certain cultural aspect to the end of life process or ceremonies that they want to do with their loved ones, then we want to try to support that as much as possible while we maintain safety for everybody. So a question NCLEX loves to ask is, a patient who is in hospice dying of terminal cancer, the patient's family wants to do a ceremony where they light candles and do a prayer blessing over the patient. Obviously, we can't light candles, right? Because it's a safety issue where oxygen may explode or we may start a fire in a healthcare facility. So we can't support them in that way, but what we can do are things like use flameless candles or flashlights or something, try to work with the family and see what they can do. But ultimately, we can ask their spiritual advisor to come in from outside, outside services. We can bring in pet therapy, just anything that will really help them make it through this time. Okay, so social or spiritual and cultural needs to be respected and asked. You need effective, open communication with empathy, making sure you're actively listening. Sit down, face your patient, wait for them to finish talking before you verbalize or formulate your response. And that's really going to give good active listening.